on the regurgitation. Can you explain it? If you find endometrial tissue in the peritoneal cavity, you can explain it on the basis of regurgitation. But in the lung or some other parts, you can explain it only through hematogenous or lymphatic. It means there are blood vessels and lymphatics within the uterus. Endometrial tissue goes inside them and goes to the different parts of the body. So this explains the presence of endometrial tissue in other parts of the body. Clear? Lymphatic and hematogenous. He's not able to stop laughing, but he's smiling. I cannot say it laugh. Yes. Anything? Regurgitation. Maybe the smile is inside, but it is regurgitating. Then another theory is metaplastic theory. What do you mean by metaplastic? You know, all this epithelium is derived from the coelomic epithelium. Embryology, coelomic epithelium. Okay? So there are stem cells. These stem cells can differentiate along all the lines. Okay? So these stem cells from the coelomic epithelium, they can give rise to the endometrial implants. So no regurgitation, no lymphatic or hematogenous spread, but arise from the stem cells in the coelomic epithelium. Another is extrauterine stem cells or progenital cells. Another theory is there, which say there are stem cells in the bone marrow. These bone marrow stem cells are responsible for this. But all the theories cannot be explained. Some theory can explain the peritoneum, some can explain the presence in the lungs or some other parts of the body. So you can take into account all the theories. You do not insult anybody. Whosoever has given, because if you find in the peritoneum, you say retrograde or regurgitation theory. Okay? If you find somewhere else, you can say metaplastic. If you find no, there is no connection between the uterus and other, you can say the benign metaplastic theory. Clear? Benign metastasis theory. And you can say the extrauterine stem cell theory. So these are the four theories. Clear? Then what you will find now? Grossly, you will find this. Small nodules, reddish brown to bluish. Small nodules on the peritoneum, on the surface of the ovaries. Normally 1 to 2 centimeters, but sometimes if they are remaining there for a longer period of time, they can get converted into big cysts. And what are these cysts? These are large blood-filled cysts, which are also known as chocolate cysts, like this. Big cyst is there, you cut it open and chocolatey fluid is coming out. It doesn't mean you will. This is a bad thing. So chocolate cysts are there, and because of these cysts, because of this endometrial tissue, it is an abnormal tissue. There will be inflammation. Whenever there is inflammation, it will be healed by fibrosis. So there will be fibrotic adhesions between the pelvic structures, between the intestines. So fibrotic adherence between the pelvic structures will be there. So this is complication. Okay, this is the complication. How you will diagnose? You can diagnose it by the presence of endometrial glands and stroma, with or without hemosiderin. Okay, with or without hemosiderin. Because hemosiderin, some of the red blood cells will be there. And now a latest addition in the Robbins is, there is one thing which is called atypical endometriosis. Atypical endometriosis. This endometriosis has atypical features, and it may progress to carcinoma. So even the endometriosis, you cannot take it lightly. Sometimes it is a high risk epithelium. It is at an abnormal location and high risk. It may cause cancer. So what are the complications? Infertility, fibrotic adhesions. Sometimes the tube can get blocked. So it can cause infertility, dysmenorrhea, painful, pelvic pain, pelvic adhesions between the different organs, dyspareunia, dysuria, and pain on defecation if the rectum is involved. And although uncommon, malignancies can also develop because it is at-risk epithelium. At-risk epithelium. It can undergo malignancy. Clear? So endometriosis is endometrial glands and stroma at ectopic sites outside the uterus. There are many theories like metaplastic theory is there, metastatic theory is there, regurgitation theory is there, and stem cell theory. and it can cause many complications, and one of the uncommon complication is the malignancy. The next thing is endometrial polyp. What is a polyp? Anybody? Polyp. These are simple projections from the, this is cavity, endometrial cavity. So there is a projection, apple-like. It can be pedunculated, it can be sessile. So there is a polyp attached to the endometrium. Like this. This is uterus and it is coming out from this. This is the polyp. It doesn't mean you will pluck it off. This is not a tufa. This is polyp. This is a polyp. See here. This one. Polyp. It can be sessile, it can be pedunculated. So mostly these polyps occur in the post-menopausal women. Can be sessile, can be pedunculated. These are the varieties. These can be hyperplastic, having hyperplasia of the glands. These can be atrophic, having dilated glands in the older woman, atrophic polyps. Or it can be functional polyps, which are functional, containing functional endometrial tissue. Now, these are not tumors. These are polyps, only the growths. These are not tumors. Okay? So it can occur in old age, which is called atrophic polyp, which will be non-functional. They can be functional polyps, which will bleed also with menstruation. Functional means bleed also with menstruation, and hyperplastic polyps. Asymptomatic means sometimes they will not cause any symptoms, and sometimes they will cause bleeding. Clear? So these are the polyps. We do not discuss it much. Just you should know there are polyps can be present in the endometrial cavity. Endometrial carcinoma. What do you mean by endometrial carcinoma?
Cancer.
It is a malignancy. Yeah, good.
Endometrial line.
It is arising from the endometrium. Okay. It is simple. Why I am asking? Because I want to take some rest. So it is the most common invasive cancer in the female genital tract. This is the most common cancer. Okay, endometrial cancer is the most common. Age is somewhat older, 55 to 65 years of age. What it will lead to? Bleeding and leukorrhea, whitish discharge or bleeding. Okay, from the uterus. What are the risk factors? Who are the female who are prone to have this? Females who are on estrogen replacement therapy for a long time. So estrogen has a role. Yeah. Metastasis can be with any of caste. Metastasis with any caste. So estrogen has a positive role. What is going on? All the people smiling, laughing and talking absent. So you decide now.
What about smiling?
Smiling absent.
Why?
Laughing also absent. You are in a class serious.
Smile.
Patient is having cancer and you are smiling. Okay, you go to the hospital, patient comes to you, endometrial carcinoma, you smile and laugh. Then you will see. You will not go back home. Will you go back? So what are the risk factors? Increase in the estrogen, like estrogen replacement therapy for a longer period. Where you need the estrogen replacement therapy? After post-menopausal estrogen hormone replacement therapy, HRT we call it. Then people who are having endometrial hyperplasia, they can also progress to carcinoma. Like dysplasia can progress, hyperplasia can also progress to carcinoma. Then estrogen secreting ovarian tumors. Ovarian tumors are there, they are secreting estrogen. So estrogen will act on the endometrium and cause hyperplasia and carcinomas. Obesity. This is a risk factor because there is increased synthesis of estrogen in the fat deposits and from the adrenal and ovarian precursors. Okay. And diabetes, hypertension and infertility. You know, these are predisposing factors. But these are not the main factors. Main factors are these.
Doctor, can't it be caused from excess of progesterone? Because it have the same function.
Estrogen,
Why?
not the progesterone.
Also
Estrogen has a growth promoting effect.
Also progesterone.
Which type of, what type of progesterone will give rise to?
Ovarian, I think.
No. What type of growth you will find in the uterus because of progesterone? What is the role?
Thickening of the endometrium.
You are sure?
Sure?
Progesterone causes what?
Thickening of the
Secretory phase of the endometrium, isn't it? Huh? Thickening of the uterus, how? Because of more secretion, isn't it? The growth promoting effect is by the estrogen. It can cause the hyperplasia and hypertrophy of the
So
cells.
estrogen only epithelial growth.
Hyperplasia, once hyperplasia is occurring, it can undergo then the carcinoma if it is uncontrolled. Because estrogen, as I told you, what happens? Estrogen, once it binds to the cells, it leads to the formation of more growth factors. These growth factors, once released from the cells, act on these cells and on the other cells also. So more growth, more hyperplasia. Autocrine and paracrine effects. Clear up to here?
Yes.
Older, where are these? You said contraceptive pills can also cause. Contraceptive pills can cause the older contraceptive pills because they contain high amount of estrogen. But nowadays there is a balance. They have kept the estrogen to the minimal amount. So no increase risk. Okay? No increased risk. Now, what is the pathogenesis? We say risk factors are there. And these risk factors, remember one thing, these are for endometrioid type of carcinoma. Endometrioid type of endometrial carcinoma. But there are two types, endometrioid type and serous carcinoma. Okay? The serous carcinoma is also known as type 2. Only 15% of the cases occurring in the older woman in a background of atrophy, because the endometrium has undergone atrophy in older women. Okay? So in a background of atrophy. This is most of the time poorly differentiated or grade 3 carcinoma. High grade carcinoma, poorly differentiated, and you will find mutations in the P53 gene in 90% of the cases. So P53, the dangerous gene, poorly differentiated, older woman. All the things are dangerous because she is nearing the death. So endometrioid type occurring in 80% of the cases. 80%. This is the most common variety occurring in perimenopausal women with estrogen excess due to any cause. In the setting of endometrial hyperplasia, so it means there will be first hyperplasia followed by carcinoma, like dysplasia followed by carcinoma. Mostly these are well differentiated. One. Then you will find different genes involved here. What are the genes? PTEN gene. The same gene is involved in endometrial hyperplasia. So there is a link. The PTEN gene is also involved in hyperplasia, it is also involved in carcinoma. PIK3CA gene, DNA and KRAS genes. Okay, all these genes are affected. But here only P53. Clear?
Yes.
So these genes are affected. And what is the hallmark of this? It involves signaling through PI3K/AKT pathway. This is the hallmark of the disease. Because all these genes are involved in increased signaling through this. So once these genes are affected, there will be increased signaling through this pathway. This is the hallmark of the disease. It involves this pathway. Tariq, Sadak, Tariq. This Tariq is involved. So all these genes will lead to increased signaling through this pathway. And it is also increased in HNPCC. This is one of the hereditary non-polyposis colon cancer syndrome. So it is, the incidence is increasing there. So pathogenesis means it can occur in older women, which is the serious variety, in younger women or perimenopausal women, which is the endometrioid type. And the difference is here P53, here the other genes, PTE and DNA mismatch repair, and the hallmark is signaling through PI3K oblique.
What does it mean? What does it mean?
This is a signaling pathway. You have many signaling pathways. Receptor is there, then there is a signaling pathway. So you have to study this, how it crosses. Because every pathway, some of the pathways are leading growth of the cells or hyperplasia. So they are in a controlled. This is occurring normally also, but in a controlled fashion. Isn't it?
Yes.
But if this control is gone, there will be increase.
How many pathways are there?
How many pathways? You want to teach me the genetics? Pathways are many. You go to the genetics of the cell. This is what I should ask you. But here in this pathway is involved. Okay? You have many pathways. How many pathways? Anybody? You know the RAS oncogenes?
Yes.
Yeah. It is also involved in a pathway. There is a pathway. Every receptor has a pathway how it affects. You know receptor?
Yes. One pathway for each receptor.
Yeah. Or many receptors can follow the same pathway also. You have to see, receptor is there, something binds with the receptor, the growth factor. Then there is a pathway, signaling pathway. Signal has to go to the nucleus, isn't it? From the surface, the signal will go to the nucleus. So there is a pathway. So this pathway can be affected anywhere.
So you mean through the cytosol until it reaches the...
Stop. For this, come to my room. This is not to be discussed here. Huh? So two types, endometrioid and the serous carcinoma. Morphology.
So the pathway is responsible for endometrial.
Endometrioid, the pathway is involved, this pathway. But more or less, every carcinoma has to be affected by the genes. And genes control the pathways, the signaling pathway.
No, but this pathway.
This is specific. This is specific. This is look, what we are saying. Increased signaling. It means normally there is signaling, but it is a controlled signaling, isn't it? No, here it is increased because of mutation in the gene.
Sir, last line, mutation in B53.
Yeah.
What will T?
Leave it. This is P53. This is P53. Nowadays they are saying TP53. Previously they said P53. P was small. Now they are keeping T and P big and TP53. Morphology, what is the morphology? Endometrioid type. Again, it can be exophytic growing into the lumen or infiltrated, going into the wall. And you can find the grades. It can be well differentiated, forming glands, moderately differentiated, solid and glands, poorly differentiated, solid sheets of cells, without glands or very less glands. And staging, stage 1, 2, 3, 4. Okay, stage 1 confined to the body of the uterus, carpus. Stage 2, it involves the cervix. Okay, stage 3 goes beyond the uterus but within the pelvis. And stage 4, distant metastasis. Clear? Very easy. It's not that easy. The staging is not that easy, but I have made it easy. Otherwise, cervical stage also, stage 1 is divided into stage 1A and 1B. Then 1A1, 1A2, 1B1, 1B2. So these are very difficult stages. But to make it more simple, confined to the carpus, confined going to the cervix, going to the true pelvis and distant metastasis. Easy for you. Serous carcinoma, again, it is poorly differentiated. All are grade 3. Okay, and you will find tufts and papillae with more psychological ADP. Tufts like this. Tufts, glomerular tuft,
Okay.
like a flower. Papillae, you know. Huh?
Yes.
Now the last thing which we will discuss, but it is a huge topic, gestational trophoblastic disease. All the diseases which are associated with the pregnancy. Okay. You have three things here. We call them as moles. Hereditary form, mole. H mole. This one. Second is invasive mole. Third is choriocarcinoma. These are the three things which are most important. And one thing is which is called placental site trophoblastic tumor. We will not discuss this thing, but you should know the name. So coming to the H mole. What is H mole? Hereditary form, mole. These are of two types, incomplete and complete. or you can say complete and partial. What is a complete hydatiform mole? It means this type of mole doesn't permit any embryogenesis. There is no embryogenesis. So you do not find any fetal parts. Okay? So in complete mole, so a patient comes to you having a swelling in the uterus, you remove it. Okay? You say it is a mole on the. But if you do not find any fetal part, no fetal part, it is a complete. Okay? So never contain the fetal parts and all the chorionic villi. You know chorion?
Yes.
So the villi? Yeah. In the placenta you find amnion, chorionic villi, all the features.
This is during.
Yeah. Yeah. So all the chorionic villi will be abnormal. And what will be the karyotype?